All right. Last year at the annual meeting, the MIT Club alumni group and the officers got together and said, we need to do some more things about social responsibility, and how can we be more active as a community group? So I was thinking about what are the big issues now that we could help solve problems about? And MIT loves a challenge. I mean, they love a challenge. So I felt like, well, could we do something about being part of the healthcare system? There's a lot of people in healthcare within our alumni group. Is there anything that we can do to make a difference, even if it's something simple? And small steps do have a ripple effect. So I do believe that a small group can make a big difference. And I'd like this to be the catalyst group. And I thought I'd throw the idea out and see what happens. And threw it on the wall and it stuck. We had a newsletter came out, and the idea was to provide a forum. And we had 16 volunteers who were going to participate in describing what it is we're going to do. So if you'd like to be part of that group, let us know. We need more volunteers and assistants to make this happen. So we're going to have a series of 4 events. So this will be the first of the series. It's intended to provide a problem statement. So this is we're identifying what's going on and taking 2 different views. The second one will probably be about technology, or we'll look at the different stakeholders within the system and look at possible solutions. So there we do have a survey at the end of the night that we'd like you to fill out to provide us with input on what our next series events should be. So this is the first one, and it's talking about single payer versus non-single payer and a managed competition. We have very good speakers tonight, and I'd like them each to introduce themselves to give you an idea about who they are, what they've been doing, and how they are they positioned for this. And then we'll start with Hal to present. So Hal Luffs and Joanne Spites are the, if I said that, I knew I said that wrong. Joanne and I have been living together on email back and forth about this, and unfortunately Joanne has not been able to meet with our group yet, so apologies for getting your name incorrect. Calarco is also a tough one, so I understand. Okay, Hal, would you like to introduce yourself?
Sure. Does this work? Okay. My name's Hal Luft. I recently retired after 30 years at UCSF. I'm a health economist by training. I'm now heading up the Palo Alto Medical Foundation Research Institute, where I'm also doing research and bringing perhaps a new realm of health services research to the Palo Alto Medical Foundation. I've been thinking about HMOs, managed care, incentives, quality, and most recently, how one can really change the system. Is that fair background?
That's great.
Okay.
I'm Joanne Spetz. I'm pinch hitting, partly. I was going to be the moderator of the event. Jim Kahn, who's a colleague of ours at UCSF, was going to come. He just flew back in from Africa over the weekend and is now nursing bronchitis. So I'm a researcher. I'm on the faculty at UCSF. In the nursing school, I teach in the policy program, and I figured I would try to channel the spirit of Jim and some other colleagues who are strong single-payer advocates. My own research is mostly on health workforce issues and health IT and the organization of the hospital industry.
To start us off, Hal? We'd like you to present to the group your position. He's going to take 15 minutes. He's going to go through his entire position in 15 minutes. One of the great things about what's going on with Hal at the moment is he has a book. So this is shameless plug time. And it's called The Total Cure, The Antidote to the Healthcare Crisis. And flyers for this are available in the back of the room. So if you want to learn more about Hal's position, there is information available. And once he talks, we'll have Joanne talk. Then we're going to have a little bit of a reaction panel from 2 of the committee members. And then we're going to open up for discussion. So we should have plenty of time for discussion, at least an hour. Okay. Hal?
You'd prefer that I stand?
Is it better if he stands, guys, or would you prefer? Yeah, okay. Let me clip this on for you.
We're on? Okay. The first thing I'd like to do is give just a very brief background on managed competition, since many of you remember managed competition from back in the 80s and then the 90s again. And that was a notion in which people would choose among different health plans. And the health plans would compete with each other and lead to a more efficient healthcare system. How one got people into choosing among health plans, there are lots of ways. You can get everybody into a federal employees health benefits type program, or you could have large employers sponsoring choices, et cetera. Alan Enthoven, in a sense, was the father of managed competition. It never really went very far because it was killed during the Clinton administration by various politicians and interest groups. I'm trying to go a step beyond that because in essence, I'm asking how, if we actually had everybody covered, would we want the system to work? So I'm saying, fairy godmother covers everybody. You wake up in the morning, it ain't all fixed. We've got quality of care problems. We've got incentives that are misaligned at the provider level. We've got a system that generates lots of data and no information. And so I've been trying to think about how we can really structure that. I've also been trying to think about what you really need insurance for and what you don't need insurance for. So let me start with what you need insurance for. You need insurance for hospitalization. It's infrequent and very expensive. Classic insurance situation. All of us would actually choose to buy it, assume we had some reasonable level of income, if we could buy it at a fair rate. The other piece is chronic illness. Not everybody chooses to buy coverage for chronic illness because, looking around the audience here, many of you are the young invincibles, and you don't need it right now. But as I tell my son-in-law who does mountain biking, who knows? Okay, so the point is we need to have coverage for hospitalization and things that are equivalent to hospitalization. If you go in, you have somebody do a laparoscopic procedure on you, you walk out, roll out, in 23 and a half hours, that's not an outpatient procedure, okay? So we blur the lines here and say, depends what's really done to you, that's going to count as inpatient. And chronic illness. So say, put everybody into, mandate that they become part of a universal coverage pool for hospitalization and chronic illness. Roughly speaking, that's about 2/3 of all healthcare expenditures for the under 65 population. Probably more for the over 65 population, but I haven't been able to get the Medicare data. What about the other 35%? You don't really need coverage for it. Minor acute problems. Do I need insurance coverage for my eyeglasses? It's covered. This is a highly predictable expense on my part. I might like the fact that it's tax subsidized, but that's unfair. My income is well above the average. It helps me move money around during the year, but that's what a Visa card is good for. Okay? So you don't really need insurance for that. Now there's an equity issue, and I will come to the equity issue in a moment because I really care about the equity problem. But the political debate has often got stuck on the equity issue. We need to cover everybody without thinking about how do we actually make the system work once you have people covered. So where would I go with this thing? I'd say for the hospitalization, it's actually relatively easy technically. Already, Medicare pays hospitals a lump sum based on the reason why the patient came to the hospital. It's called a diagnosis-related group categorization. It's a bundle of money, and the hospital needs to manage its resources within that bundle. It's doing so, however, with one hand tied behind its back because the physicians are paid fee-for-service. So the doctor says, I think this patient needs an MRI. And the hospital says, yes, sir, and eats the cost of the MRI, while the physician gets paid the fee for interpreting the MRI. So I would change that and move to what I would call an expanded DRG that would cover physician and hospital services, including a little bit of pre-admission services and an appropriate amount of post-discharge services, i.e. the patient has a complication because you left a sponge in the belly and has to come back in, the original hospitalization pays for it. So you have an incentive now to figure out how you keep those sponges out of the belly. it gets more complicated than that, but much more interesting in a moment. The payment would go to what I'm calling a care delivery team. That care delivery team is a voluntary association of hospitals and the physicians who work in that hospital setting. Not just the anesthesiologist, radiologist, pathologist, but also the surgeons, also the invasive cardiologists. And they would have to figure out their governance. They would have to figure out how they move money around amongst themselves. And they could do all sorts of things that right now are illegal. For example, it's illegal right now for a hospital to say to its orthopedist, you know, there are 36 varieties of hip prostheses, and you could probably do with 6 if you could agree on which 6 you wanted. It's illegal for them to get together and say, these are the 6 we want, and for the hospitals to say, we'll share some of the savings of not having all 36 varieties sitting on our shelves. Can't do that. Illegal. The hospital may have empty operating rooms on Saturday and Sunday. They can't tell the doctors, you know, we'll give you a little bonus so that you can operate on Saturdays and Sundays and golf on Mondays and Tuesdays. Can't do it. Care delivery team, you're able to do that. Much more importantly, the care delivery team now has the incentive to start asking questions about exactly what procedures, what techniques, what interventions really work and for whom. Okay, that's the inpatient side. Big bundle, about 40% of all expenditures happen on that inpatient setting. Outpatient. That's where the world becomes much more complicated because it's not just a small team. It's lots and lots of different physicians who are treating you at various points in time who actually, you know, I thought when I started out in health economics that you knew what a diagnosis was. And then my physician friends told me, you know, patients don't walk in with an ICD-9 code on their forehead. That's what we have to figure out. Okay? And patients like the ability to choose doctors and move around in ways that are far more complicated than any managed care organization is able to work out. That's one of the reasons why managed competition failed, because patients wouldn't choose a team for everything. So what we're saying here is choose yourself a primary care physician. That primary care physician, let me call this Dr. Kiley. Dr. Kiley takes care of you and a whole bunch of other patients. And Dr. Kiley needs somebody, some organization, to handle the billing. And so what Dr. Kiley does is he chooses a payment intermediary. He only needs one. Have you seen 12 different credit card machines in a restaurant? No, they have one. It's designed so it can read whatever credit card you have. And there's a switch electronically that sends those credit card slips to the right place. Okay? So one payment intermediary, Kiley chooses it. Let's call it Orange. Now, Orange could be a reformed Blue Cross or Blue Shield plan. Could be Schwab, PayPal, Visa, or some new entity that is yet to be derived here in Northern California. Because all it needs to be good at doing is processing claims, moving paper around, bills around, etc. But it does a couple of other things. So it very quickly finds out what Kiley's costs are for the patients he has. And Kiley goes to this universal coverage pool, not Kiley, the payment intermediary, Orange. Every time a claim goes through with diabetes on it for a new patient, Orange lets the universal coverage pool know, and the universal coverage pool ships to Orange a monthly amount that represents the average cost of treating somebody with diabetes on the outpatient setting. If it's inpatient, it pays directly. So all of a sudden, Orange doesn't have to worry about risk. Kiley can have lots of very sick patients with lots of chronic illnesses or very few. Doesn't matter, because whatever they have, the universal coverage pool starts shipping money. But it ships the average cost, not what Kiley actually charges, not what Kiley actually uses. So Kiley now has a real interest in understanding why Dr. Welby next door has premiums, because that's the net cost, right? You take the total expenditures, you net out what's coming in for chronic illness, and that net cost is what goes to the patient. So Kiley's patients start complaining at the end of the year. And Kiley says to Orange, hey, guys, can you offer me some information? You've been processing all my bills. Are you anything better than Visa? can you look at that information and tell me why my charges, I'm sorry, not my charges, why the premium costs for my patients are higher than for some other docs? And say, oh yeah, we can do some analysis here. We can notice, for example, that every time somebody comes in to you with a back pain, you refer them out to your friend, Dr. Scalpel. And what Scalpel does is he does an MRI, and 40% of those patients with an MRI go on and have surgery. Seems as though what Welby does is he calls a doctor who's an orthopedist, who seems to, and he pays him a fee. Now, no reason why fees can't go from doctor to doctor. This is a consultation. And this other doctor says, you know, wait 3 weeks and see if it doesn't go away. If back pain goes away in 3 weeks, I don't need to see the patient. If I see the patient, I'm probably going to be obligated to do an MRI. And a lot of people with no real problem have something that shows up on an MRI, and then once I see it, I have to do it. Okay? So that's why Welby's expenditures are low, because he's practicing differently. And Orange looks at all that data, and it will have access to everybody else's data as well in a de-identified fashion. So what I'm trying to build here now is a system where, remember, has universal coverage. That's the everybody's covered part. It has information or data flowing around through, you start with an existing claim system and you start adding other information as the clinicians demand it. And you have a demand for information from clinicians asking, how can I practice better? Now, there are a whole bunch of other aspects to this. Equity. Because not everybody can afford that basic premium, and not everybody can afford that 30% that, quote, is uncovered. You can do an income-based equity subsidy behind the scenes as those credit card slips get moving around. For some of them, they get discounted. So if your income's low enough, you might only be paying 5-10 cents on a dollar. But the physician gets paid the same amount. They don't need to know that you're being subsidized. There's no reason for that. They're providing the same services to you as anybody else. So we can do income-based subsidy in the background as much or as little as we want. That's a political decision. I'd argue it's also a moral decision, but there aren't very many moralists in the Congress. So one of the questions here is, can we start getting everybody with that 60 to 70% covered guaranteed? That's the first stage, which actually there's more than enough money in the system right now to cover that. And for everybody else, you can start saying, well, you know, the middle class don't need to be subsidized for those minor acute problems. If they want to move the money, spread it out over the year, they can do that. They can buy coverage. A couple of other features to this thing. It means that the demand for information on what works and what doesn't work says that you don't need to worry about what's in the benefit package. You can have the FDA cover anything that doesn't kill people. And it ought to actually help some people. But the decision now is not, does it get into your benefit package or not, which is what currently happens. Huge fights getting somebody to cover a new drug or device or whatever by CMS. Say, no, it's covered. It's up to the doctors to decide when they want to use it. And they'll start deciding it's not very useful in many instances. In a few instances, I'll use it. Because they're now the ones who are going to be more responsible for what the costs are. And you build in assessments on outcomes so that the payment level, I would argue, should be based on whatever it costs by those care delivery teams in the upper half of the outcome distribution. In other words, everybody should be guaranteed that the money put on the table is enough to get you superior care. Not average. That's what Medicare pays right now. Medicare pays DRGs based upon the average across the country. I think average isn't good enough. It ought to be superior. But if you bundle it together, everybody in the superior category is going to try to reduce their cost, which over time will start reducing everybody's costs. Okay, so there's a lot of blue in this and a lot of red. A lot of market and a lot of equity. A couple of important points that were laid out. Okay, so I think it meets the goals of access, cost, and quality. Can it work at the state level? sort of in an early implementation phase, but the real goal of this thing is to change the trajectory in healthcare expenditures. And you can't do that with a state. It will happen, I would argue, if you change it nationally. That the people in biotech will start saying, now wait a minute, where is my market going to be? Is my market going to be on the drug that helps a few people and gets sold to many? Or will it be on the drug or device that helps many or increases quality by more than enough than what it's going to cost? Because people are going to be out there assessing this, not somebody in the federal government, not somebody that we can politically strong-arm, but individual doctors and patients. I would say that's going to change the market model enormously. Any evidence that it will work? No one's really tried it. The closest that we could argue we've come to this is end-stage renal disease, where for a long time, Medicare has said, we'll pay a fixed amount, you guys figure out what you're going to do. And there's been changing technology, increasing efficiency. It doesn't work really well, but it's probably the closest model we have. What I'm trying to do here is build something entirely new. So we need to try it out. What needs to happen for it to work politically? Well, there will be a new president. We're not quite sure who that's going to be. There'll also be some change in Congress. I'd argue that there's probably enough red and blue in this that either side could get behind it if they really wanted to focus on the cost issues. And there are people like Peter Orszag, who's head of the Congressional Budget Office, who are saying there is an enormous downstream problem that we're looking at in terms of federal liabilities for Medicare and Medicaid that needs to be addressed now. And so actually, if people start saying we need to do something about changing cost, at the same time, we also have physicians and others who are tired of being beaten up in the system. They have total leeway to do whatever they want in the system, but they have to bear responsibility for what they're doing. They can set their fees, they can set their practice styles, they can do anything they want. The insurance companies are gone, the payment intermediaries work for the doctors. But the doctors are then responsible to their patients as to what their premiums are going to be. And anything that MIT CNC alumni can do. There are a lot of opportunities here to think about the information issues, how one builds those switches, how one collects information and shares it, and makes it usable to mostly physicians first, and then patients. Patients don't make lots of decisions of the kind that I'm talking about. It's really a technical decision by the physicians. How can we really get there and do that stuff in a usable way? And then, of course, vote. Thank you.
Thank you. We have to change.
Yes.
Oh.
Yeah. Your tags.
Yeah, no,
Oh.
it's just easier. There. All right. Is that good? Close enough? Awesome. Okay. Let's see. I've been asked to make the case for single payer. And I think making the case for single payer in the United States is hard to do because most people confuse single payer with single provision. So single payer is, most people think that's Canada or that's England. But single payer technically does not mean single delivery system, which is where Canada has tried to go. It also does not mean socialized per se, where the government runs the whole system. Single payer means very simply that there is a single organization that handles all the health care payment. Think Medicare. What if Medicare was covering everybody instead of just the elderly? If you wanted to use the pejorative term socialized, Medicare is a socialized health care program that people seem to be willing to accept because it serves a population that has substantial risk and was uninsurable on the private market. Given that at this point competition appears to be failing pretty miserably in health care, We have 42 million people who are uninsured. That's the non-elderly uninsured. We've got growing healthcare costs because all of these organizations are basically gaming it to make money at this point. That consumers don't have any incentive to look at costs, nor do they necessarily have the resources to make a cost-quality trade-off. There's a whole variety of research that shows that even when people like you and me can get on the internet and go look at all these hospital report cards and physician report cards, how many people in this room have ever looked at one of those? Like maybe half, maybe a third. So if you are all not doing it, what do you think about people who did not get a college education? In fact, what % of people in this room have a postgraduate education? Yeah, pretty high. So if I've made the statement before classes of nursing students where I've said, okay, if you as nursing students, as healthcare professionals, aren't looking up this information and don't know what to do with it, how do you expect the broader population of Americans to be looking at quality information and trying to make decisions and thinking about these things? So we know that the costs are growing tremendously. There's very little incentive to focus on the quality issues. The organizations like a hospital or a doctor gets paid pretty much the same amount of money if they provide mediocre care versus excellent care. There's also huge private profits. And, given that we've been talking a lot about the banking industry lately in this country and huge profits and what's appropriate and what's not appropriate and perhaps unwarranted profiteering, if you begin to look at the amount of money that some of these healthcare organizations are making as publicly traded entities or privately held organizations, there's a lot of money flowing around there. Estimated as ranging anywhere between 13 and 30%, depending on the company. So it's 13 to 30% profit to an insurance, profit plus administrative cost to an insurance company. Physicians are spending a substantial amount of their time and money just trying to manage billing, which is not a good use of a physician's expertise, to say the least. So there are a lot of flows of money that don't seem to be going where we ideally would want them to. And, given, I'm going to be very curious to see how all of this plays out over the next year or two, because it's my understanding that the recent ban on short sales of financial firms also applied to health insurance and HMOs. And I'm trying to figure out why that was included in there, but I'm sure there's some interesting story behind that. Now, single payer, if we said Medicare for everybody, which would be the simplest way to do it. Medicare is a program that we love, we accept. Well, some people might not love it, but we accept it. It's deeply ingrained in American society. What are the benefits of that? Well, first, you can go straight out and say, look, everybody's going to be insured. Nowadays on Medicare, even if you don't fill out any paperwork at all, you are guaranteed to get the hospitalization portion of the health insurance. So that falls into the person who didn't fill out the health insurance card, this is my brother-in-law, thinks he's, young and invulnerable and is never going to have a problem, ends up carted into the emergency room in a car accident. Medicare would cover him. You don't have to do anything to get that basic insurance. You can guarantee that everybody has some kind of a primary care insurance if you want to. You could say, okay, Medicare for everybody is going to include your doctor coverage for basic care. It's going to cover your hospitalizations. That doesn't mean the government owns the hospitals or employs the doctors, but it's the payment mechanism. You can explicitly debate costs. And this is a place where I think our country is weak because we don't have a single payer or centralized healthcare system. Nobody's quite sure where that money goes, and there's a general sense of, well, how is it that we can cover Viagra, but not every child is getting vaccines? It seems like the money's maybe not always going to the types of care that are the most beneficial. You can make those discussions explicit. If it's everybody's tax dollars that are very clearly paying for the system, then you have an opportunity for an explicit policy debate, which I'm an optimist. I still think that maybe that'll happen someday. You can set forth quality goals. You can say that, look, as our national healthcare system, we are not going to cover a program unless the research demonstrates that it's effective. If we can't show that this drug or this medical treatment is appropriate or effective and cost effective, we're not going to do it. That's what most of Europe and Australia do nowadays anyway. You also can cut out a lot of administrative costs. And, on the surface, it's like, oh, administrative costs, how much could that possibly be? Well, the estimates are anywhere between 10 and 20% of healthcare costs are in administration. Medicare is 2%. So much for government waste. I mean, so if the government was really sloppy and spent double that, you'd still save money just by getting rid of all of these private insurance companies that are shuffling paperwork around, and then all of the private doctors that have to try to figure out all this paperwork, and then the hospital billing departments, which last time I walked through a hospital, it seemed like there were nearly as many people in the billing department as working on the patient care floors. And so you can get rid of a lot of administrative costs, and we're not talking about a trivial amount of money here. Now, is this feasible? I don't think this country is going to go Canada style. It's just not in our blood as a country to trust our government that much to employ the doctors. And we hear horror stories about Canada, many of which are unfounded. But we hear the horror stories and we say, oh, we don't want that. We don't want the English system. But the notion of having Medicare exist for everybody, I think, is pretty feasible. And you could, if you really wanted to go there, you could allow options for people to buy insurance above and beyond that, like people buy Medigap insurance now. So access, quality, costs, I've discussed. Could this be done at the state level? It's actually been proposed at the state level. What's interesting in California is that Sheila Kuhl has put forward a bill, I don't know how many times now? How many years in a row has this gone in there?
5 or 6.
I think the legislature has even passed it 1 or 2 times, but it's always been up against a Republican governor, so it's never gone past that point. This could be done at the state level, although how exactly that would interact with the federal system is not clear. And when you have, say, private companies that are insuring their employees that have multi-state organizations, there are a lot of questions about how well that can play out at the state level. But, as with House program, as a pilot, might not be a bad place to start. But has it been tried elsewhere? Well, there are a lot of different countries across Europe that have programs that are variants on single payer, or variants on, not really purely British-style socialized medicine, but somewhere in the continuum that we could use as benchmarks. Australia's system, for example, actually in some ways doesn't look that different than Hal's, where all the tertiary care, all the kind of the big hospitals, the teaching hospitals, all that care is centralized and paid for by the government. If you want any care, you can get it through that system. If you want to buy a supplementary private insurance program, you can. So you could create that kind of a structure if you wanted to give Americans choices. What can alumni do? Health reform is extremely complex, and it's interesting this election year because there are a few good websites where you can get side-by-side comparisons of the presidential candidates' proposals, which are starkly different from each other. Read about this stuff, because whichever person wins, this is probably going to come to the table. Certainly you're already starting to hear things like, if we can afford to spend $700 billion on the bank industry, how come we can't manage to insure people? Those discussions are going to persist. Now, President Clinton, it looked like he had a lot of traction to move forward with health reform, and it got stymied. And I think it's in the interest of all people who are looking at these issues to try to step beyond the rhetoric of, oh, well, single payer is just socialized medicine, and we don't like socialism except in banking. So we're going to, we can't do that. Because actually single payer is not necessarily socialized medicine, and it's not necessarily any more socialized than what we're doing already. If you think about paying for the uninsured, we already are all paying for the uninsured, but there's got to be a more efficient way to do it. So a lot of these preconceptions and buzzwords that people throw at us to make us look badly upon one proposal or favor another proposal, we have a responsibility to try to look deeper than that and really cut down to, well, what are the core presumptions that are being made in each of these policies, and does it make sense or does it not make sense?
Thank you very much.